Guidelines recommend initiating statins for primary prevention of atherosclerotic cardiovascular disease based on absolute ASCVD risk assessment. And now, how you come up with that assessment, that is hotly debated. And there are trial-based and hybrid approaches for statin treatment eligibility and recently risk assessment guidelines from the ACC-AHA. So we're talking about a paper that's coming up in the JACC December 22nd, 2015 issue. It is selecting patients for statin therapy in primary prevention if we could only predict the future. I'm with Dr. Vera Bittner, who is a professor of medicine and section head of general cardiology, prevention, and imaging at the University of Alabama, Birmingham. So your commentary is actually on a paper from Denmark, and it's a team evaluating primary prevention, and it's kind of taking a look at these different approaches. Why were you asked to do this, first off? This is an area where you are an expert.
Well, I mean, I wouldn't go that far, but I reviewed the paper, and I guess Dr. Fuster liked some of the comments that I made about, the paper itself. So, the paper compares in the Copenhagen general population the ACC-AHA guideline recommended approach, i.e. the new risk calculator, with a trial-based approach, and then with a hybrid approach that takes into account risk factor, risk prediction, and trial-based entry criteria. So that's what the paper is about. And what the investigators concluded in this population-based cohort, that the ACC-AHA proposed calculator actually performed better than the trial-based approach and the hybrid approach.
I talked to Dr. Norden Gesgaard, and he was kind of, surprisingly, the ACC-AHA guidelines were better, and it was just kind of a shock. This was hotly, and still is, isn't it, hotly debated?
Yeah, I mean, it's very hotly debated because, as a clinician, you have to make this decision day to day in the clinic. Right. Do I treat this person or do I not? And none of us have a crystal ball that really tells you whether this person will have an event or not. And so when you think about strategies, that you could use, I mean, you can use the, calculator and look at the risk factor constellation, or you could say, well, I mean, in the clinical trials, a certain group of people derive benefit. So if I pick my patient according to the trial entry criteria, maybe I have a better chance of predicting who will benefit, or maybe I can use a combination of both. And it turned out that in this general population, the calculator actually performed better.
And overtreatment was one of the criticisms early on regarding the fact that that was what people were expecting from the changes, in the guidelines.
Right. So overtreatment is a concern, and the other concern that people had is that so much of the risk in the calculator is actually driven by age, and so the question then comes up. Age is fundamentally non-modifiable. So if I identify somebody as being at risk because of age, does that necessarily mean that they benefit from treatment? And people fall into two camps. One says, no, I mean, if the risk is driven by age, I can't fix the age, so that doesn't tell me anything. Right. And then other people would say, even if there are other dominant risk factors, lipids are a key portion of atherosclerosis development, and so when you look at some of the PCSK9 mutations, those people who have low levels of LDL throughout their whole life, they don't tend to get atherosclerotic disease even if they get other risk factors, including advancing age. And so, right now we don't know who's right.
But we do know that this is not the first time that investigators have found that the 2013 ACC-AHA algorithm is well calibrated, at least to that 7.5% risk range, correct?
No, I mean, there was an analysis from the REGARD study, actually from Paul Muntner, who is also at UAB, and using basically identical methodology to what the folks in Copenhagen chose to use, also suggested that in regards, which is a general population in the United States that's contemporary, that the risk calculator performed quite well as well.
In your editorial comment, you write, "So what do I tell my primary prevention patient in the clinic tomorrow?" So that's my question to you.
Yeah, and I think you kind of basically have to, individualize. You have to take all the pros and cons into account and discuss those, with the patient. So, I don't think that we have evidence that's so incontrovertible that you can just, dogmatically say you have to go and take a statin. Right. But I think you can present, the clinical trials data. You can present what the risk calculator, spits out for that particular patient, and then you can make a joint decision whether to proceed with treatment or not.
And the guidelines emphasize the fact, talk to the patient. I mean, it's that statins conversation.
Yeah, exactly. That's a key component. The other thing that I thought was kind of interesting in that paper from Copenhagen is that the three approaches actually identify different individuals. So when you look at the Venn diagram, each identified a portion of the population, but the overlap in those three risk-based approaches was only relatively modest. So that ends up, putting another whole wrinkle into this risk prediction. And then there was an 8% group that wasn't identified by anybody. And what was kind of interesting is when they looked at those data a little bit more, carefully, that those individuals had high Lp(a) levels. And so maybe that is something that we should pay, closer attention to in the primary prevention setting.
Well, they were talking about some markers within the guidelines for cholesterol. Was Lp(a) one of them?
We really don't know how they, kind of fit best. What was, emphasized the most was coronary calcium scoring, because that kind of, tells us, who already has disease and who doesn't. And then you can look at inflammatory markers, Lp(a) levels, more detailed look at family history, and so on and so forth, trying to individualize.
I think essentially what they showed is that the ACC-AHA guidelines will prevent more ASCVD events than trial-based and hybrid approaches, and at least compared with the trial-based approach, it will achieve that by treating fewer people.
Correct. Yeah, that was their primary conclusion. And so, but I think right now we're well served with the calculator-based approach that is currently recommended.
Do you think this will end the debate at all, or at least tone it down a little, or is this just going to continue?
Well, I think that the debate is going to go and continue until we have some hard data. The problem, I guess, that I see is that, we will never have, totally airtight data in the primary prevention population, because the trials are incredibly expensive to do, and there will always be population groups that fall outside, the trials. And so, I guess what it boils down to is that we have to be doctors in the clinic and actually think a little bit instead of just, by cookbook trying to decide who to treat and not.
Right. Well, the original paper and the editorial comment by Dr. Bittner are in the December 22nd issue of JACC. Please check that out for CardioSource World News. I'm Executive Editor Rick McGuire.